Well, good morning, everybody. My name's Mike Kelly. I'm from Cambridge Public Health, where I lead on the Health Inequalities pillar, which was led jointly with John Ford, who's speaking at this event today. I'm also from the Department of Public Health and Primary Care. But before I did that, I ran the public health team at NICE. And as with all the work that NICE does, we were consumers, avid consumers, voracious consumers of evidence. And all the pieces of work we did, as with everything that NICE does, begins with a search for the evidence and an assessment of the quality of that evidence. And that's really perhaps the most time-consuming part of the whole business. Now, when we were doing this, when we began this about 20 years or so ago, the process was incredibly slow. Although, of course, we had the major big databases that people could search, and we had computer technology to help us to do that, it was still a pretty laborious, person-intensive business. And even when you got all the papers, sort of sorting them out and working through them took ages and ages. And of course, at the same time, the volume of stuff that was being produced in all of the areas, but particularly in some of the things we were particularly interested in the public health stream at NICE about behaviour change and health inequalities, the literature was simply burgeoning, and it didn't matter how good and how assiduous you were in searching for the material, you were out of date more or less as soon as you stopped looking. The volume of stuff was unmanageable, essentially. The other thing to say is that if you were trying to dig into that literature and seeking to understand issues relating to health equity or health inequalities, it was complicated or made complicated by the fact that the material was actually quite difficult to find within this mass of stuff, notwithstanding the technologies that were available to us. And I suppose in the end, sometimes it was simply the case that we knew by the time we'd finished the literature search, even though as every minute went by afterwards, it was getting more and more out of date, that much of it was describing the problems rather than defining solutions. Well, of course, things have moved on technologically. And one of the things that, or one of the developments, of course, has been the application of artificial intelligence to this process, or more advanced techniques, I suppose, is another way of thinking about that, rather than jumping on a kind of AI bandwagon. But either way, the technologies have, their capacities have also increased and improved. And what John's going to talk about is a centre that he's involved in at Queen Mary University in London now, which has found ways of getting into this literature much more swiftly and much more efficiently, in effect. Now, I'll ask John in a couple of seconds or two to begin his presentation. But could I say, if you have any questions, would you please post them in the Q&A function, and we'll try and answer questions through that route. Use the chat if you can't get into the Q&A, but please use the Q&A so we can monitor what's come in and who's been answered and so on. And there'll be an opportunity when John's finished for a more general and open discussion. So without further ado, John, can I ask you to introduce yourself and to take us through your presentation? Thank you.
Great. Thank you very much, Mike. So I'm John Ford. I'm an academic public health doctor. So I'm medically trained and I've specialised in public health. I work as a senior clinical lecturer in health equity at Queen Mary University. I've got an honorary position at Cambridge Public Health. I also work as a consultant in public health at NHS England as well. It was a privilege to be in Cambridge for 4 years or so, where I, as Mike said, we co-led the health inequalities pillar. But to be honest, Mike was the brains behind it, and I did most of the legwork. I'm very grateful to all that experience, which has fed into this project today. So I'm going to start at the end of my presentation. throughout this presentation, I'm going to talk about something called living evidence maps. And I just want to give you an idea of what they look like before we start. So let me just give you a quick demonstration of what I mean by a living evidence map. And then hopefully during the presentation, you'll be able to know what I'm talking about. So when I say living evidence map, this is what we're referring to. So they're maps which show where the evidence is and where it's not. So hopefully you can see this. This is an example of one of our maps, and it shows different primary care interventions, different disadvantaged group categories, and it shows you how much evidence. So each green circle refers to umbrella reviews, so that's reviews of reviews, and each blue circle refers to systematic reviews. And within this map, you can see that there's, for example, lots around ethnicity and community link workers, 98 studies, and you can click on the circle and it gives you the 98 studies. You also see where there's not evidence. They're living in the sense that they're kept up to date. And so I'm going to take you through how we've used machine learning to develop these living evidence maps. So let me just get back to the slideshow. So over the next maybe half an hour, 40 minutes, I'm going to run through how this project started, then go through some background around, why do we need to automate and how does this improve our current techniques. I'll then go through the machine learning opportunities and process. We'll take that fairly slowly, assuming that you don't have much knowledge around machine learning. And then I'll give another quick demonstration of what it looks like and what it can do. So the project started probably about 18 months ago. We got some seed funding from NHS England and from the primary care team in NHS England. They asked us to do three main things. One, they wanted us to create these living evidence maps of what works to address inequalities, and they wanted us to focus on primary care because that's where the funding was coming from. They wanted us to do some data analysis work around where inequalities are, which we've done, and then they wanted us to put it all together on an online hub and resource center. I'm going to mainly talk about this living evidence map work of using machine learning, and you can find out more about the data stuff on our website. But that's how it originated. We're about maybe 9 months into the project, and the plan is then to continue beyond the 18 months. So to start off with, why should we automate? Why do we need to introduce machine learning? What are the opportunities? So you may be familiar with this systematic review process. So it starts off with, deciding on a research question. Once we got a research question with some inclusion-exclusion criteria, we then do a search of the electronic databases. So that could be Medline, Embase, various other ones out there. It usually refines down into anything between 1,000, 10,000, 20,000 articles. And a researcher then spends time screening all the titles and abstracts to identify articles which meet the inclusion-exclusion criteria. Articles which do meet that inclusion-exclusion criteria are then the full text of them pulled to review whether they still meet the inclusion-exclusion criteria. They're then extracted, the data is extracted, they're synthesized together, reports written and submitted. So that's kind of a breakdown of the systematic review process. For those of us who have done them for years, they'll be very familiar with this. And the time that it takes to screen these titles and abstracts takes quite often months. Certainly when I started my career, I worked for one of the evidence review groups, which did reviews for NICE. And we would quite often screen through up to 10,000 titles and abstracts, and two people would do it independently. So we'd have two people screening through 10,000 abstracts or titles and abstracts, and it would take literally months for us to do. So we know this whole process takes a long time. Some previous research has estimated that it can take an average of 16 months from agreeing the research question to finally getting a publication. Like that's fairly good going considering the the time it takes to get something published these days. But it takes a long time. If you build in the need to apply for funding, it can take well beyond 3 years by the time you apply for funding, secure funding, recruit a team. So it takes a long time to do these systematic reviews. Clearly, there's much more rapid reviews which can be undertaken, but in terms of a traditional method, they take a long time. They also take a lot of labor, a lot of researcher time to do. So I just want to give you an example of how much time it can take. So this is a systematic review of looking at the risk of dementia, chronic cognitive impairment after mild traumatic brain injury. And the authors or the researchers in this study screened through almost 78,000 research articles. So they spent months and months screening through almost 80,000 titles and abstracts. From that 78,000 titles and abstracts, they identified about 300 that were eligible and which they reviewed. Of those, they then got rid of about 200 because they weren't methodologically acceptable, didn't meet the methodological standard. And then they found 8 articles which referred to dementia or chronic cognitive impairment. So out of that 78,000, they ended up with 8 articles. So they must have spent months. I tried to imagine how long they spent screening all those titles and abstracts manually with one person looking through them all to identify those 8 articles. So we know it takes, not only does it take a long time, it takes a lot of researcher time as well. So you need kind of almost full-time researchers doing this. They also go out of date, as Mike referred to. By the time you do a search, the time it takes to screen all the titles and abstracts, extract the data, synthesize it together into something sensible, and then write it up, can take, again, previous research has estimated 8 to 22 months, that whole process. So that means that actually by the time the publication, by the time the article is published, quite often the literature review is out of date. So this 8 to 22 months is the time from the date of the search to the date of publication. Sometimes people update the search before publication. That can be a good way to make sure it doesn't go out of date. But quite often, these systematic reviews are out of date by the time they get published. We saw that all the more clearly during the COVID pandemic, when it was just increasingly difficult to keep on top of the literature. That's not even to mention that after a year after publication, 2 years after publication, they're even more out of date. So trying to keep reviews up to date is becoming increasingly difficult. And that's also increasingly difficult because the number of publications is just almost exponentially increasing. So this graph shows the number of publications looking at primary care and inequalities. And we can see, in the past 10 years, there's almost been a 300% increase of the number of articles being published looking at primary care and inequalities. We see this not just in primary care and inequalities, but across the board. There's this year-on-year growth of the number of articles being published. And so keeping on top of that is becoming increasingly difficult and unmanageable. So this current model of doing systematic reviews is becoming increasingly unsustainable, in that we've got more research being published than ever. And our search strategies are getting better, and we're getting better at finding it, but that means that we're having to screen more. The types of reviews we're doing are also tending to get a bit more complex. So again, maybe 30, 40 years ago, we were doing systematic reviews of single drugs on single conditions. actually, we're now looking at much more complex um, problems in our systematic reviews, and especially around models of care, for example. Uh, as all as all sectors are experiencing, there's a limitation of resources. People wanting more value for money through research. And actually, there's lots of new opportunities with machine learning, which I'll come on to, which can ensure that we reserve human expertise for the most impactful part of the process. So in terms of machine learning opportunities, there's a few different ways in which machine learning could support this pathway. So the main one of which I'm going to talk about is machine learning classifiers. So this idea that we're able to classify or categorize studies into certain groups using a machine learning algorithm, and we use it to priority rank, which I'll come on to explain about. So I'm going to mainly talk about the first one. We're also at the minute exploring how we could do some data extraction using machine learning. So that's when we've got an article which we like, which we think's appropriate. Can we use a machine learning algorithm to pull out some of the key details from it? There's also machine learning software which maps research activities. You might have come across things like Research Rabbit or LitMap. So there's software which then map on, and we use a bit of this. So certainly for some of our literature reviews, which I'll come on to show you, some of our evidence briefs. Once we've got a group of studies, then we the kind of quality assurance using some of those software packages, just to which helps us to identify anything we've missed. And there's also now machine learning packages which will write briefs for you. We've never used those. Like some of the times that we've experimented with them, they're not nearly good enough to be supporting this process. Who knows if they will be in the future. Certainly our principle has always been to automate that which could be automated. So we try and automate the processes which take a lot of human effort. We really believe in this idea of augmentation. So using machine learning to automate the things which machines are good at, and using human expertise to leverage the things which humans are best for. And that means, by using these machine learning classifiers, which we've used, we can create these living evidence maps, which I'll come on to explain how we do that. So in terms of the process we've used, so first of all, we identified a set of training materials. So we just finished a NHR funded review of what works to address inequalities of primary care called Equalize, and I'll tell you a bit about that. We then use that training material to train an algorithm, and we then, once we trained the algorithm, employed it on OpenAlex, which is this open source database, a bit like Google Scholar, which has 200 million plus records. And we put some belt and braces with citation tracking and related articles, which I'll tell you a little bit about. That gives some priority screening. Again, I'll go on to tell you a bit about what that looks like, and that means that we can do this process every month, and every month the algorithm gets a bit better. We can add new studies in, and our evidence maps stay up to date. Based on that, we then produce evidence briefs. That's where the human element comes in. So we have researchers who then pull some of the studies together from the evidence briefs or from the evidence maps to write briefs. So that's an overview of the process. I'll just go through each of those steps a bit more slowly to help you understand. So this is our original study. We were funded by NHR to do this review. It was an 18-month review. It took us about 18 months to get funding, 3 years in total. We spent, I was a full-time researcher on it for 18 months. And we produced this article, which we were delighted to get published in Lancet Public Health. But we had a feeling of, actually, once we published it, where do we go next? How do we continue this going, and that's how it fed into this machine learning algorithm. We spent a lot of time identifying key studies. So we went through a process of looking through about 8,000 titles and abstracts to try and find about 250 systematic reviews. And those 250 systematic reviews we unzipped. So we looked within the primary studies of those reviews. And so that meant we reviewed another about 6,500 records, and we eventually came up with this core set of 325 records, which looked at what works to address inequalities in primary care. So that meant we had two groups of training material, one of systematic reviews, which have looked at what works to address inequalities in primary care, 250 of those, and 325 primary studies, which looked at what works to address inequalities in primary care. And that's what we used as our training material. We supplemented with a few other reviews as well. And essentially, that training material looked like 251 included studies or studies which were relevant, and then about 7,750 ones which we'd excluded. So we had a small pile of included ones and a big pile of excluded ones, and that's how we could train the algorithm. We did it using something called a bag of words approach, and that involves vectorizing the titles and the abstracts of each article. So to give you an example, this is an example which looks at randomized controlled trials. So if we're looking for to teach an algorithm using this bag of words approach to identify articles which are randomized controlled trials, this gives you an example. So if you look along the row, at the end it tells you whether it's relevant, one or not. So one is yes, it's relevant. Zero is no, it's not. So ones would be our included articles, zero would be our excluded articles. And essentially, the words at the top are different words which have appeared in different abstracts and titles, and whether they match onto our training material that manual labels relevant. So in this example, randomize and range appeared in the first article, and that was relevant. In the next article, random and randomized appeared, and that was relevant. In the third article, ranitidine and systematic appeared, but that wasn't relevant. So that was one of our excluded articles in this example. And if you can imagine this whole process by going on for thousands, tens of thousands of words, and not just 3 articles, but 8,000 articles, then you hopefully get an idea of how the kind of matrix works. It doesn't just look at single words, but also looks at combinations of words as well. And essentially, using either fairly standard regression techniques or neural network approaches, we can then calculate coefficients. So again, in this example, randomized has the highest coefficients. It's most strongly associated with included studies, whereas systematic in this example has the lowest coefficient, so that's least associated with our included studies. So if you can see, then we end up with a whole suite of coefficients related to different words, and that's a suite of coefficients which can then be used in a different data set. So this is how we trained the algorithm using this bag of words approach. We used software developed by UCL and Epicenter, and so we've got a collaboration with them. So that's how we created the machine learning algorithm, training it with that software package. And essentially, once we've then trained the algorithm, we can then apply those coefficients to a whole different set of data. In our case, it's OpenAlex. When those coefficients are applied, they allow each article to have a probability of how similar that is to our included or excluded studies. So that means that we can essentially rank all those studies from these are the most similar one to the least similar. So in our case, we use OpenAlex, which has at the minute about 250 million articles. So essentially, we rank those 250 million articles from the most similar to the least similar using those coefficients from our training set. And so that creates us essentially a priority ranking system. Clearly, as we go through the process, this kind of the coefficients improve as we add more and more data. So as we make more and more decisions, we retrain the algorithm, and so that way it's keeping up to date. And the priority screening process looks a bit like this. So at the top is a traditional screening. So for those of you who've done systematic reviews before, you know, something when I did it, you might have 10,000 articles to screen. You might screen the first 100 articles. And if you found 5 articles, you could multiply that up to think actually, if I find 5 in the first 100, and we find 50 in the first 1,000, by the time I get to 10,000, I might have 500 articles. This is going to look like too many. But that's because you expected a fairly similar rate throughout the whole screening process. Whereas what we're doing here is we're essentially pulling the best articles to the very top of the pile. So that means that actually we just have to look at the top of the pile, and it's never going to be perfect, but it's going to give us most of the articles. In reality, what it looks like is something more like this, where actually the number of studies we can then look at goes on for millions, rather than just a few thousands or tens of thousands. Ideally, what we're looking for is this kind of automation performance, and we've certainly over the past 9 months or so saw much more improvements in our automation performance. So this graph shows the number of studies being screened along the bottom, and the number of studies included along the vertical axis. The grey line, which just goes diagonally across, is what we find with a kind of traditional search. We'd kind of expect a fairly standard or fairly consistent rate of included studies. Clearly, if our automation's good, it looks like the yellow. If it's very good, it looks like the green. If it's bad, it looks like the red. And the whole idea is that actually, if we have a good automation process, then we only need to screen 10-20% of the articles. In our case, much less than that, because we're screening because the algorithm's being used on over 250 million articles, but we only need to screen a very small proportion of them to identify the included studies. So that means that actually for us, we screen maybe about 300 or 400 titles and abstracts every month. Because we're just looking at the top of the pile, we put them into our living evidence maps, and that means that we can keep them alive and up to date. If we're doing this in a traditional way, we might have to rescreen every month, but that might be in the magnitude of thousands. And actually, because it's pulling the best ones to the top and it's getting better all the time, then we're finding that actually the numbers we're needing to screen is coming down. It's particularly good for these fuzzy topics. So something like inequalities, as Mike alluded to earlier, can be, the studies around what works can be difficult to find because they cross so many different disciplines. And therefore, using something like this machine learning approach means it's because the algorithms trained in similar studies. As long as our training materials good, then actually it's good at identifying similar topics and similar studies. So it's good for these kind of fuzzy topics. It's less useful for single drugs for single conditions because actually our existing search strategies can do that fairly effectively at the moment. So we found it really useful. Like, it's taken us quite a long time to set up. It's maybe taken us about 9 months to get going and set up. So again, it's worked well for something like inequalities, where we've got quite a broad topic, and it's something which will continue to be relevant across a number of different topics for a long time. Again, it would work less well for a single drug in a single condition, for example. So that's what we do with priority screening. To top up the priority screening, we add in some network graph searches. And so network graph searches uses related articles within OpenAlex. So how we use that is essentially OpenAlex has, as I say, about now 250 million papers. And it pulls in articles from lots of different areas. So from PubMed, pulls in PhD and master's theses and all sorts. Within that data set, within that database, we can also do network graph searches. So they already have a function where they identify about up to 20 similar articles per study. Again, they've got their own algorithms about how they identify those, but they're added into the priority screening. So you may have seen before, if you go on a journal website, if you're looking at a specific article, it's got some related articles or suggested reading or something like that beside it. And that's essentially what OpenAlex is doing with these related articles. We also do some forward and backward citation tracking. So that's, this has been done for years, but again, we can do this in using the software rather than having to manually do this. But this is essentially looking through all the references within within an included study, and then looking at all the future articles that cite that included study. So what it looks like was kind of additional security that after priority screening, we add in these related articles from OpenAlex, and we do citation tracking in terms of forwards and backwards citation tracking. And both of those means that we're fairly confident we're getting most of the key studies. Again, the whole idea is not to find every single article under the sun on a topic, but to find the fairly robust body of evidence which can inform decision making. And once we've added in those citation tracking and related articles, then they feed further into the algorithm and into the living evidence maps. What we then do as a team is we then produce some evidence briefs. So we work with 6 integrated care boards across the east of England, and some in London, northeast of England, and they give us suggestions from around what to look at. So we take suggestions for evidence briefs from ICVs, and because we've already got a living evidence map with the studies included, we can then produce a brief summary of the evidence within about 4 to 6 weeks. So to give you an example, Suffolk and North East Essex, we're doing a piece of work around how to improve physical health checks for people with severe mental illness, and they asked us if they could what the evidence was around what works to improve physical health checks for people with severe mental illness, and we're able to look at the evidence maps, pull it out, have a researcher look through about 15 studies or so, and write an evidence brief for them within about 4 to 6 weeks. We use grades, which you may have come across, to try and communicate the certainty of our recommendations, and that's partly because we're using this principle of transferable evidence. So part of the purpose of setting up the centre was to try and build some capital knowledge around what works to address inequalities, and particularly in primary care at the moment. And the idea is that as we go through different topics, we can use that transferable evidence. So we may not have direct evidence on what works to address inequalities in hypertension for Somali populations, but we may have evidence on different sub-Saharan African populations. So this whole idea of how we logically apply transferable evidence to inform decision making is key to what we're trying to do. So, for example, with our Equalize study, we had some evidence-based principles which came from the literature. Again, applying them in different topic areas has been important because we feel like as decision makers, I guess a more comprehensive approach to evidence-based recommendations. We're not setting out here to do systematic reviews in the traditional sense. We're not setting out to try and find every article under the sun. Actually, we want to pull out the best and the key evidence and communicate that to decision makers in a helpful and useful way. We've set up or we're in the process of setting up a agreement with a journal. And so the idea is that actually these evidence briefs, once they're published online, then we'll have a pipeline to academic publication as well. The evidence briefs we've done are shown here. So we've done stuff on cervical screening, health checks for people with severe mental illness. Also looked at self and digital triage in primary care and how to address inequalities. We've looked at healthcare or access to primary care for asylum seekers, migrants, refugees. With how to address inequalities in self-referrals in primary care, primary secondary care interface, and cholesterol management. And these are some of the other ones which we're working on at the moment. So one around funding, blood pressure at home, the use of general practice estates, hypertension case finding, high intensity use and continuity of care. Again, those are the topics which are coming from ICBs, which they're wanting evidence on. So I just want to finally just give you a bit of a run through around what the evidence maps look like. Let me just share my screen. Wait just a sec. So hopefully you can see that screen. So this is our website, or all our evidence maps are publicly available, so anyone around the world can have a play around with them. At the minute, we've got about 11 evidence maps up there. We can cut the data in lots of different ways because we've got a coding framework which studies are tagged with. We can cut the data in lots of different ways. So these are just the ones which we happen to cut by. And I've shown you some examples, but you can have a look at your own time. Like we're hoping that these will be useful both to researchers when you're preparing grant applications or writing articles. They also give us an idea in terms of where the evidence gaps are. So it's quite easy to see actually where there's less studies being published. At the minute, we've just got systematic reviews and umbrella reviews in these evidence maps. But we've just been working on the primary studies, and so hopefully in the next few weeks we'll also have primary studies included in these maps online. At the minute, as of today, we had about 406 systematic reviews included in across all the maps, and we've got about 460 primary studies which are waiting to go in. So in total, we'll have about 870 or so studies across all the maps. So again, in time, hopefully that'll increase a bit more, but actually we're reasonably confident. We've done some quality assurance of them, so we've done some kind of cross comparison with PubMed and Medline and Embase to get a feel, and we're fairly confident that certainly with the systematic review data, we've got a good body of literature there, and we're getting more confident with the primary studies. The evidence briefs are also publicly available, so those are the 7 we've got there, which you can have a look at your leisure as well. The final thing just to say before I open up to questions or comments is let me see if I can just get my slides up again. Um, is to say, there we go. Uh, I guess final things to say is, we're really looking to connect. We've got a LinkedIn and Twitter account where you can follow us. We've also got a mailing list. If you go onto our website, you can subscribe to our mailing list. That's a kind of monthly newsletter, which highlights all the new content. But equally, feel free to drop me an email. I'm happy to connect. That's the end of my presentation. I'll hand over or hand back to Mike. Next part.
Thank you, John. That's an extraordinarily exciting development, and I must say, I'm very envious not having had access to that kind of stuff back in the day when we were trying to pioneer these sorts of ideas. But anyway, there are some questions that have been posted already, and what I propose to do is I'll go through them. The first is from Isla Kuhn, who is from Cambridge, someone that John and I have worked with. And she says, incredibly impressive, but given that it only catches reviews, which are likely already to be out of date, will you be expanding this tool? I think you may have just answered this, to cover primary work and so make it that much more up to date. John.
Yes, yeah. So we've expanded it. I guess it was a bit easier to do the quality assurance with the systematic reviews. So we published that first because we were more confident in the systematic reviews, and we're just doing a kind of quality assurance of the primary studies. So we've got about 460 at the minute, which are we've got the evidence maps, but we're just making sure that we're confident of them. So the primary studies, I'm hoping, will be released in the next few weeks once we finish off our kind of quality assurance process.
Yeah, good. I mean, what I think's particularly interesting about the idea of summarizing the reviews of reviews is that's pretty much what we did years and years ago at the Health Development Agency. And I can remember when we first started to publish them, there was some degree of skepticism in the academic community that these were going to be out of date twice over for the reasons that Isla has said there. However, I do have to say that once we started to publish them, and funny, we call them evidence briefings, you've called yours evidence briefs, but once we started to publish them, I know that policymakers and people who were practitioners, policymakers and practitioners found them particularly useful as a very quick way of finding out what a map, as you've described it, of the evidence looked like at any given moment, regardless of the problems that may have generated in terms of distance from primary studies. But it's good to know that you're moving into the primary studies themselves. The next question is from Rishi, I think. The indexing and ranking algorithm, they say, is somewhat similar to the way Google uses for websites and articles, and that we know that these indexing methods can be manipulated by using the right words to get to the top of the list, even when the quality isn't good. Would that be similar in this case, John? Can the system be gamed by using the right words to be captured?
Still, I don't think that's an issue at the minute. In that, at the minute, I don't think researchers are publishing with that in mind, with specific, for example, or specific living evidence maps. Like in some ways, it's already happening in the keywords that researchers use. So for those of us who've published, you have to add some keywords, and that helps databases researchers to find articles. So there is conceivably a way of choosing the keywords. Like my gut feeling is that it's probably not much of an issue. And I think I think one of the key things that I've had to emphasize quite a few times is actually, our training material has all come from fairly robust review that we did for NHR, and actually we use OpenAlex, which is also a fairly robust database of research outputs. We don't use Google or ChatGPT or anything like that, and so it's something like ChatGPT relies on the wild west of the internet to generate data. So again, we're not really exposed to those kind of biases, although undoubtedly there's always biases within the literature we pick up, as is the case with most reviews actually. We tend to have a English speaking Western bias um, in the studies we pick up.
Yes, indeed. The next question comes from anonymous attendee. I don't know who you are, but they're saying that, are you sure that the inclusion of all disadvantaged groups, say for example people with disabilities, children in care, and so on? Do you just want to say a little bit, John, about the way that you've operationalized your notion of inequality here?
Yeah, great question. So we've essentially got three main buckets. One is around elements of disadvantage, one around interventions, one around outcomes. Essentially, every study gets labeled with something one of those three, and it needs to meet all three criteria to be included. So it needs to have some element of disadvantage, some intervention, and some kind of health outcome. When we created those tags or those lists, categories, we drew on some existing frameworks, something like Progress Plus we used. Although Progress Plus isn't perfect by any stretch of imagination. And there's a few other kind of frameworks out there produced by just England think tanks, which we drew upon. And like some of the disadvantaged groups we included initially, it just was so little evidence, and I think we weren't confident we were picking up enough of the data to include them. So, for example, we originally had categories around learning disability and autism, but we didn't have much evidence within the maps, and we weren't confident enough that we were collecting that body of evidence. So there were some of them which we didn't think our initial training material had sufficiently captured. Yeah, I think in the future, like our next step, I think we probably want to iterate our categories, and we want to think about actually what's going to be most used to decision makers and practitioners. So I guess that's a roundabout way of saying actually, we tried to draw upon the existing literature and existing frameworks to come up with those categories. Actually, I think at some point in the future, we probably want to have a look at them again to make sure they're all on topic.
Yeah, it's a difficult, well, it's potentially a complicated problem. I suppose the other overlay on that, which was always a difficulty for us at NICE, was the failure of many studies to think in any way intersectionally about the relationships between different dimensions of social difference, focusing instead on single or perhaps a couple of the characteristics rather than thinking about the broader issue.
Yeah, and that's certainly what we've found in literature. There's very few studies which look at that intersectionality or multiple disadvantage. I should also just add that we've included both studies which look at the gap in terms of gap between socioeconomic groups or between ethnic groups, but also targeted interventions in specific disadvantaged groups. So it might be actually for people with severe mental illness or Gypsy Roma traveller populations, for example. So we've included both the gap and targeted.
The next question, have you validated the priority searching by comparing it with manual search of the same evidence base?
So we've done some of that ourselves,
Yep.
Which we haven't published or not, or published. And actually, we found early on the algorithm needed quite a lot of additional work. So our initial training material wasn't quite good enough. And actually, by the time we added in the network graph searches, so that citation tracking and related articles, that's what made an improvement to it. And actually now we're fairly confident. So or validation or quality assessment
Yeah.
later on has been much better. I know the group in at UCL Epicenter have published some stuff where they've compared manual searching with um, this priority screening method. So they've published some of their own data. Like I suspect it's very dependent on the research question and the training material. But actually, I think we're fairly confident now. We've got good coverage of the systematic reviews, and we're hopefully getting there with the primary studies.
Yeah. Good. Um, Lihani Duplessis asks, have these methods been published?
Yeah, again, I'm happy to share a list of publications. Certainly, this priority screening method has been published, and yeah, again, the epicenter at UCL have published a lot of the methodology. We're currently working on our kind of flagship paper, writing all this up. Again, that won't be a detailed methodological paper because the methods have already been written up on it, but I'll be more describing the evidence maps we've found and our process.
The question from Sarah Kelly, how much time does it take to train the algorithm for each review?
Good question. So, like our personal experiences, it took 9, 12 months. The actual training of algorithms is a fairly short process and it takes days, but actually getting it to a point where it's useful it's taken us probably 9 to 12 months. And that's because we had to do quite a lot of screening at the beginning to quality assure it, and then we had to tweak it a bit because we weren't convinced we were picking up all the best articles. It took a fair amount of time of iteration. I guess um, that's a part of that broader point. Actually, I think this is only really worth doing if it's for a broad topic over a long time period. I think it's not really at the minute working well for a single review, which is going to start and finish within a year or 2 years. And it doesn't quite feel like it's there yet in terms of setting these evidence maps. Undoubtedly, some of the other machine learning techniques can support existing reviews. So certainly with an EPI reviewer, they've already got a process where if you're doing a review, they can make some suggestions around which other articles would be relevant. Things like Research Rabbit and Lit Maps do that as well. So I think there's other machine learning software which can support the review process. But this whole process of setting up living evidence maps feels like something which needs time and investment over the medium to long term.
Indeed. Nick, sort of echoing an earlier question, Nick Fahy asks, comparisons with, in terms not just of accuracy, but resources and timeliness. Is this a more, is it a less resource intensive and is it more timely? I think you kind of hinted at this, John, but
yeah, again, the UCL group have actually published where they've compared it. Like certainly from our perspective, it's taken a good 12 months to set this up, and so that's actually been a huge time intensive process in terms of we've had collaboration with the UCL group who've been helping with some of the technical aspects. We've had some researchers doing priority screening, and then we've had some other people helping out in the background. So it's taken us quite a lot of time to set up. But now that we're in and going, actually, we're publishing one of these evidence briefs every month or so at the minute. So over the year, we'll probably do about maybe 10 or so. So actually now is when the efficiencies really coming into play because actually we're now able to turn around things much faster. So I think over the long term it'll be much more efficient.
yeah.
In terms of accuracy, actually, we're not setting out to produce literature reviews which are in-depth, comprehensive, systematic reviews. Actually, I think we're fairly confident that actually the studies we're picking up are the main key studies which are useful for practitioners and policymakers to inform decision making. So, I think we feel confident enough we're getting enough good material and enough robust studies to do that. So I think it's accurate in the sense of meets our needs to support decision making. Like in terms of academic systematic review, um, yeah, who knows? I suspect it varies from topic to topic.
Yeah, and I guess it depends what you need the evidence for, doesn't it? You know, the reasons you would do a particular kind of academic traditional systematic review and the reasons you need access to information quickly about the shape of the evidence now um, will depend very much on the kind of questions you're interested in and in many ways who you are, as you've suggested. There's a question from Victoria Bartle, about other evidence centres using this screening approach. You've mentioned several times in the course of the presentation, John, your linkage and working with Epicenter at UCL. And of course, at UCL as well, linked to that same Epicenter is the Human Behaviour Change Project, which was led by Susan Mickey and Robert West and others, which is not doing the same thing, but is also sort of pushing forward this whole thing about screening quickly, live reviews and all that sort of thing. So if you Google the Human Behaviour Change Project, you'll note that. But John, are you aware of where the other hotspots in this kind of activity are at the moment?
So I'm not aware. So again, Epicenter have done stuff around COVID maps. NHR have just got a call out at the minute to create some living evidence maps. And so I suspect in the next few years there will be more of this coming on board. Like I'm not aware of other groups doing what we're doing at the minute and trying to make it as I guess open source and publicly available.
Yeah.
I suspect in time more and more groups will. There's a kind of resource issue around how do you get core funding to keep it going. Maybe a blocker.
Well, watch this space. I think, in fact, I think it's highly likely, as you say, as time goes on, we'll see more and more of this kind of thing. And indeed, we'll see new developments technically and technologically, which will enhance the process. It is such a long way away from where we were 25 years ago, turn of the century, trying to work out, you know, how to do evidence-based medicine and evidence-based public health. I'm really struggling with the first of all, the idea that it was even a good idea to search evidence in this way and check it out, and second, how you would do it. There's an interesting question here from Anonymous again, and it's about non-English language publications. What's the thinking in relation to automating with non-English language publications, John? Do you know?
Yeah, so at the minute, we would include non-English publications if they had an English title and abstract. So for those of you familiar with databases or journal articles, quite often non-English speaking articles would have an English title and abstract, which then goes into the Medline PubMed, whatever. So those kind of articles we would already include. If they're purely written in a different language, then we wouldn't include them. And that's just the way we've set up our training material. Clearly, in time, it'd be nice to include them. There's no reason why we couldn't include them in that. Hopefully, that kind of bag of words approach, which I explained, means that you could do it for any language. Just happens that at the minute we've only done it based on English titles and abstracts.
Yeah, again, I think technically it probably isn't an insuperable problem, and one that one might expect in the next several years to see developments across the world in this regard, actually. So yeah, I mean, it's been a huge problem really as far as the development of EBM has been concerned. The focus on the Anglo-centric focus in terms of language, but I think that will move on and change in due course. Couple of other questions I see. Several people saying how much they've enjoyed the presentation, John. An anonymous person says, could you go further to help the end user by providing the facility to download linked abstracts on the summaries, or even to use ML to summarize key conclusions?
Yes, at the minute we don't have functionality to show the abstracts within EPReviewer, within the living evidence maps. It's something which we're which we're trying to explore. Clearly, we can't share full text or anything like that because of copyright.
Yeah.
So it still relies on someone having access to it, although we have been able to share with individuals. It's certainly something we'd like to get on to because I agree that would be helpful for the user, but we don't have that functionality within the software at the moment.
Okay, well, I think that exhausts the questions in the Q&A function at the moment, but I can see that Nick Fahy's got his hand up. Nick, do you want to ask a question?
Thank you, Mike, and thank you very much, John. I was really impressed by the work and by the presentation. Thank you very much for sharing it. We're also working on similar things. I'm based at RAND Europe these days, which is an independent, not-for-profit research institute, and we're trying to use some of these methods as well, as I'm sure many people on the call are. And I wonder if there's something that we could all work on, which is about some kind of a guide for policymakers about what kinds of reviews are appropriate for what kinds of question. Because we're still slightly bedeviled by the sort of, we've spent so long passing the message about the importance of being rigorous about evidence and about quality and standard of evidence and different types of reviews, which was all very helpful to do. But I think it sometimes means that there's now a message that unless it's a proper manual 3-year systematic review, that it doesn't count. And I think it absolutely does count, but maybe it would help if we could collectively work on something that would help people understand when it's useful and why. And also, as you, John, as you were saying, those types of questions when it's not useful. I just wondered what you both thought about that.
John?
Yeah, so I think that'd be very useful. Like, I guess my having worked in the NHS for a while, and with various policymakers, I think they often look at academics and think we ask the wrong questions and the wrong timescales. And so I think being able to provide timely evidence briefs, which are good enough for their decision making purposes, and having some kind of guide about the proportionality of that would be very helpful. I think it's almost a two-track system where we're able to turn around quick, rapid literature reviews, which kind of build an evidence base and use that transferable evidence, whilst also doing in-depth reviewing work as well alongside it to make sure that actually when we do the rapid stuff, it's fairly robust and comprehensive. Not sure what Mike says or thinks.
Well, Nick, I think that's a good suggestion, because I think there remains a major difficulty, particularly as we look toward policymakers rather than necessarily practitioners, where the way that policy questions are first of all framed, and then the way that the answer to that question is imagined, remain often within a very narrow range of ideas. So, in the dealings I have still with government, there's an assumption that the answer to almost every problem is behavior change. Let's do more behavior change. And it's just locked into a kind of way of thinking that is difficult. I think we've got past the idea that you could just have any old evidence, and the notion that evidence review and being systematic and so on is more deeply ingrained than it certainly once was. But I still think there's it's an epistemic issue, actually, the way the problems are thought about in the first place. So I think it's not just a two-stage process. I think there are several things that need to be done in our conversations with policymakers, which is, well, this is the evidence, this is what it means, and this is how it can help you. And I think those last two things, this is what it means and this is how it can help you, is often where we on the academic side of things are rather remiss. We kind of leave it for others to interpret, and of course they do, and not necessarily in the ways that we would think accords with what the evidence actually says. So yeah, I mean, you and John should be talking to each other. RAND would be a good organization to kind of lead this, I think, or certainly to be involved in it with academics, such as those working at the epicenter at UCL and John and various other teams. Now, I can see people are beginning to drop off the call. So it probably is about time that we drew it to an end. I can't see, I don't think, any more questions in the Q&A. I'll have a quick look. Some people saying how good it was again, John, so that's good. I don't need to repeat that. But it was an excellent presentation. It's really exciting stuff. It's so nice to see how things have actually progressed over the years. So I'd like to bring proceedings to a halt. First of all, by thanking John for his presentation and for, opening this up, I think, to a wider audience and pushing on with what I think is some very, very important scientific development. Second, I'd like to thank Helen Watts and Becky Wolf from Cambridge Public Health, who set it up and organised everything and made sure the whole thing functioned extremely effectively. And of course, I'd like to thank all of you for attending and listening. I think we will be making the presentation available. So Helen or Becky will be in touch with those who did attend it, explaining how to download the presentation if you want to have a look at it. And in the meantime, I wish you a pleasant afternoon and thanks very much for all involved. Thank you. Cheerio now.